Hip spine syndrome is a common entity, though we don't see a lot of hip arthritis here, but I think in Western world it's quite common. And McNabb was the first to describe it in 1983. Now, there are different etiologies for both of these problems, and in a patient's age above 45 years, radiographically you will see hip OA in more than 27% patients, and out of which about 10% of the patient will be symptomatic also. Now, as Guru Raj pointed out that it can be of multiple types. A simpler type will be where both pathologies are there, but we have a clear source of symptom. But like what Dr. Iyer just showed, that in a complex pathology, there is no clear source of symptom, or both the pathologies are actually contributing to the symptom. And secondary is when the hip is contributing to the spinal symptoms. So these complex pathologies pose a problem to decide which need to be treated first, and what should be the order. However, I think the careful physical examination is the key, and imaging will usually confirm the diagnosis. However, I just happened to see this patient 2 days ago, and I was lucky to click this picture and put it in my presentation. So this is like really posing a problem. Patient previously operated. I don't have the patient's MRI, but you see that there is a very severe hip OA on the left side, and previous spine instrumentation done. On close look, there are some loose screws in the sacrum, and maybe the topmost L3 screw is also loose. But on clinical examination, I found out that the patient's primary problem was coming from the hip joint. So he was already admitted under an orthopedic colleague. So she underwent THR yesterday, and I'm sure that she must be doing good. So hip OA symptoms can be overlapping with spinal pathology. It could be radiculopathy, and in certain cases it could be numbness also. But primarily, if the groin pain is there, then there are more chances of that the patient symptoms are coming from the hip joint, and especially if it is associated with the limb. In a younger population also, there could be femoroacetabular impingement, which can be CAM or pincer type, and they can be a sign of early osteoarthritis, and with the reduced flexion and internal rotation of the hip joint, and these also require special consideration, especially in the younger age group. Spinal stenosis will have its own picture of radiculopathy, numbness, claudication, typical shopping cart sign. There might be neurological involvement also leading to decreased sensation and motor weakness. So in this particular paper, there were 420 patients were assessed, and out of these 4 patients had both spine and hip pathologies. Now, interestingly, all the patients underwent epidural steroid injection, and they all did go well. But there were 4 particular patients who didn't do very well. Still, the patient was operated for spine surgery, and though these patients didn't respond to a concomitant hip injection, but after spine surgery, when they didn't do better, these 4 patients underwent total hip replacement, and after that they got better. So the picture is not very clear, and then even after doing all the investigation, you can still be having difficulty in trying to find out the right source of the patient symptom. Lateral hip pain, again, it can be from spine or hip, but of special note is trochanteric bursitis, which can be very well tackled with the help of a local injection, which will lead to diagnostic, and if you put steroid also will have therapeutic effect as well. Knee OA poses a special problem, though we know that hip and spine both can have referred pain to the knee. However, knee OA can itself have the pain around the knee and can have the pain going down to the knee also. Knee radiograph and in younger patients, an MRI can usually resolve the issue. However, the knee injection remains the last resort to confirm or refute the diagnosis. We need to also keep the other differentials in mind, like peripheral vascular disease, diabetic neuropathy, various pelvic pathologies, and vascular claudication. Now, coming to the hip injection, to differentiate between hip origin or spine origin of the pain, hip injection, if it reduces your symptoms, it is having good sensitivity and specificity. The advantage of that decision office test, which can be done in the clinic itself, and which will reduce unnecessary patient discomfort as well as a lot of investigation. And if you have concomitant pathologies both in the spine and hip, but the hip injection gives patient significant relief, then there is a fairly good chance that patient will do very well after the total hip replacement. On the contrary, an epidural steroid injection, even if it doesn't give relief, then we are not too sure. I mean, if it gives relief, then spinal pathology is confirmed to be the source of patient symptom. But even if it doesn't give relief, still the spinal pathology can be the cause of patient's primary symptom. So coming to the question, the spine first or knee, hip first. So basically, there is no clear-cut answer in the literature. It's all based on our personal choice, and but if you feel that particular patient is suffering from the hip pathologies being more symptomatic, then obviously, like we would like to get that hip joint replaced first and vice versa. But I think in many cases, we are not able to differentiate, and I think you just have to speak to the patient and take a call, like we are doing this hip or spine first, and then you might need another surgery also, as Dr. Ayer's case had shown. This busy slide was already shown by Dr. Gururaj. So primarily what it's saying that if hip is significantly affected and it responds to the hip injection, then you go ahead and do the hip surgery first. If there are clear contracture in the hip joint, then you first refer the patient for hip replacement. However, if there is significant stenosis with patient not responding to the hip injection, then primarily spine surgery should be done first. So take home message is for us as an orthopedic surgeon is that whenever you are seeing a patient with suffering from the hip pathologies, always look at the patient's spine. And if you are seeing a patient with a spinal stenosis, always have a look at the patient hip also. Thank you.